Hi, my name is Jamil. I'm one of the faculty at Cedars-Sinai Medical Center in Los Angeles, California. And I've been asked by the Digestive Disease Week organizers to uh, talk to you briefly about our poster cap-assisted endoscopic mucosal resection for non-ampullary duodenal adenomas. Um, Non-ampullary duodenal adenomas are seen in patients other than familial adenomatous polyposis. And the EMR techniques for removal of these non-ampullary adenomas are not standardized, but most published studies have looked at freehand snare techniques for their removal with a reported success rate ranging from 55 to 98%, with up to a 37% recurrence rate, with actually a fair rate of complications. To our knowledge, the sole use of the cap or cap-assisted mucosectomy for removal of these adenomas has not been well studied. So we performed a retrospective chart review of patients with non-ampullary duodenal adenomas that had EMR procedure performed with the cap as their main method of removal. And we reviewed our data dating back to 2004, and we identified 39 such patients. They underwent a total of 56 upper endoscopies for the removal of 57 polyps or adenomas by one of two endoscopists. 5 of these patients had familial adenomatous polyposis, and they had a total of 18 polyps. The majority of these patients, 85%, only had one polyp, and 96% of these polyps were flat, and about 80% were in the second portion of the duodenum. These were reasonably sized polyps with a mean size of 18 by 24 millimeters. 4 of these patients had polyps these polyps attempted to be removed by other endoscopists prior to us seeing them. Prior to performing the mucosectomy, all these polyps were injected with a fluid to create a cushion, and the fluid in the majority of the times was normal saline with epinephrine. On occasions it was hypertonic saline, and the majority of the times that was mixed with some dye such as indigo carmine. In addition to the cap, in 5 patients we also used a free hand snare technique, and in 4 patients APC was also used. When we looked at our eradication rate, when we excluded patients with FAP or patients who had not had their follow-ups, we noted that 75% of these polyps were completely removed in one session. 14% required 2 sessions, 7% required 3 sessions, and 1 polyp required 4 sessions for complete eradication. This was on a mean follow-up endoscopy of 7.7 months. We did note residual adenomas in about 13% of polyps. There was some primary closure of the mucosal defect performed in 28% of patients by clips, and this was on the discretion of the endoscopist. There were some complications as expected, and intra-procedural complications such as bleeding were noted in 5 procedures for 9%, and these were all treated endoscopically with either a coag grasper, APC, a bicap, or a clip. 2 patients had post-procedure bleeding presenting as melena, and these were treated with either an APC in one patient or a clip of a visible vessel in another. We did not appreciate any perforations in our procedure. When we looked at the pathology of these adenomas, 57% were tubular adenomas, 28% were tubular villus adenomas, and 14% had either low-grade or high-grade dysplasia. So we feel that EMR cap is a safe and highly effective method for removal of non-ampullary duodenal adenomas, and I think more studies are needed to compare it with either ESD or freehand snare endoscopic mucosal resection. And with that, I thank you for your attention.